Hope everyone's doing all right. My merciful deed of the week was sending you the article in Biomechanics, so you wouldn't have enough time to read it before this presentation. And you can thank me later. You don't realize what a favor I've done you. Because this, once you get into the class, it'll make a whole lot more sense, but it can be a little confusing at first. But I wanted to kind of go through it and simplify it, and then we can layer in detail into the thoracic spine biomechanics. A good way to start talking about this would be to talk about that. These are all models that exist within that we look at. There's different models that are out there. The one that is widely accepted is the one that is from Diane Lee in the thoracic biomechanics of these movement patterns, of what is normal movement patterns at the segment, at the facet joint, at the ribs, in the typical normal vertebral segments. And they're a little different in the upper segments versus the lower segments. And we'll get into more detail, certainly in those. But it's a starting point, is where I like to think of it. And this is my starting point when I look at thoracic biomechanics, is in the optimal spine, this is how it should move. But everyone we see beyond there are going to be less optimal. And there's going to be changes. And if I see somebody with a bit of scoliosis, I then take these biomechanics and I change them a little bit. I think about, okay, well, they're concave to the right, and that's a side bend to the right. So I think about right side bending mechanics. So as much as these don't have to be the gospel of where everyone is and everybody starts in this position, you need a frame of reference to start from to then be able to say, okay, let me move a little to the left or a little to the right within these. So just good to kind of have that just so you see. So that's my kind of quick preface on spinal biomechanics. And again, we can go into the article in a little bit more detail. Real quick, thoracic biomechanics, lower thoracic spine and thoracolumbar junction. We look at these regions, it does function more like the lumbar spine as these joints blend in. And we'll spend time looking at the thoracolumbar junction as a unique unit that allows for a little bit more rotation than some of the other segments. The mid-thoracic spine, they talk about functioning more independently as the thoracic spine. Certainly in the upper thoracic spine, in the cervical thoracic region, we're going to kind of share similarities in movement patterns with the upper cervical spine. So these things will kind of relap. So we have like the lower transition zone, upper transition zone, and mid-thoracic spine. Let me move my one window here. In Diane Lee's model, she will talk about different regions of the thoracic spine, and the vertebromanubrial region, which is going to include the first two thoracic vertebrae, the ribs 1 and 2, and the manubrium. Like you'll hear Eric will talk about, sometimes we'll include the third one in there because we'll look down as low as the third one. So we'll look down as low as the third one for this. The vertebral sternal region, these notes aren't available to you, but I'll send them out, includes the third rib to the sixth rib and these segments as well. And this is where the vertebrum come in and attach more traditionally to the sternum. And then we also have the vertebral chondral region, where this is kind of where, T7 through T10. We have the ribs attaching to the costal cartilage in the chondral space. So these regions, and in particular the facet joints, or the joint alignment of the vertebrae at the costotransverse joint will be slightly different because those costotransverse joints have a slightly different alignment as we get lower into those regions. I'm trying to move some windows around here so I can see. All right, let's talk about forward flexion. Forward flexion, as we talked about in the lumbar course, is going to be initiated from the hips. And, the thoracolumbar junction is going to contribute to it, the upper thoracic spine, the mid-thoracic spine's a region that probably contributes in the thoracic region, probably in the normal spine, the least to it. So again, we'll see variations in somebody who may have an excessive kyphosis or develops a thoracic hypermobility due to a lack of hip or pelvic control. We can think about that person who doesn't have that anterior, doesn't initiate it with a posterior translation of the hip or an anterior pelvic tilt. they developed this thoracic dominant strategy. So I expect to see excessive thoracic flexion in that individual, who doesn't have that anterior pelvic tilt. Or we can think of that individual who's all pelvis and they contribute very little to the thorax variation. But think about the motion typically initiating from the hips and thoracolumbar region and then progressing through as we look into forward flexion. Sorry. Definitely. We'll look at different. Now we'll get into some of the biomechanics that occur within the thoracic spine. And as Eric and I talk about, and I mean Michelle and all we can talk about it too. These are, the other fellows out there. It's like, this is an area that we do treat biomechanically. It's probably the area I manipulate the most, in the spine, because there's so many joints and so many mechanisms of restriction that can occur. So thoracic rings T3 to T6. Here we have if we're looking at forward flexion kind of in this region, one thing we think about is we have these superior, vertebrae gliding forward and kind of upward on the inferior vertebrae. The ribs in this diagram, as you can see, there's going to be a bit of forward rotation motion that occurs at the ribs with the forward flexion that we have. And we can think about like the ribs and how it's going to go. Now, in this region, the facet joint on the transverse process is more concave, and the rib is a more convex shape. So there's more of a rolling motion that occurs at this segment. And it's kind of indicated by that rolling motion you see in the arrow there on the right, where it rolls from the posterior to the anterior. And you see the small arrow there up on the right as well, showing that you see this superior kind of glide and roll. And that's because in this area that you have this thing now, as we get into the lower segments, like 7 through 10, that costotransverse joint becomes more planar. And it changes the glides a bit. Now, again, not significantly, but it changes the glides a bit as we look at that. And Diane Lee will go into some detail on how these glides are slightly different. But for the time being, it's good to just get a sense of, as we see this individual who, if we go back to the prior side, is forward flexing. In my mind, what I think about is this is what I see happening at the joint segments. And I think, can these joints move in this plane? Can the vertebrae glide go anterior? Can my inferior facet on the superior vertebrae glide superiorly on the facet joint beneath it? And does my rib at the costotransverse joint have that anterior roll? And here's a slide I put in there for, you have the ribs here. We're gonna have that forward rotation of the rib. The head of the costovertebral joint has basically kind of a rotary moment. And again, other than the first rib, which we have as the head of the costovertebral joint, we'll have a joint on the superior vertebral body and the inferior vertebral body. So it'll span the disc at that segment. And again, that's important sometimes because it's kind of performs like a stabilizing T-on, as it were, that segment. And that's part of the proposed model, why you don't see thoracic disc herniations being as a significant problem as you see in other areas, because of the stabilizing mechanism of this. It's been sometimes kind of been referred to as almost like an oncovertebral joint, and the costovertebral joint's ability to stabilize this joint. And again, we have a concave tubercle on the rib. I have that correct? Yeah, the concave superiorly costotransverse joint. Okay. Now we're gonna have is in the yeah. I wrote that wrong. Basically, it's going to be concave is going to be on the basically the costotransverse joint, and the convex shape will be on the rib as it rotates that way. So that's just an error in the typing there. And what that allows for is like that coupling motion. So if you can see my hands here, if this is the transverse process, I think of this shape as being the costotransverse portion of the rib. And as I get an anterior roll, when I get a motion like this, so if I kind of cup one hand inside the other hand cup, again, the outer cup and the concave one is going to be the transverse process, and the convex one will be the rib, and it's going to have that anterior spin as we lean forward. Now, in the costochondral region, which is going to be T7 to T10, in this region, the costotransverse joint is described as being more planar and flat. And the orientation of this joint kind of wings out posterior a little bit more. So the orientation of the joint is often referred to as being basically anterior, lateral, and inferior as it angles. So you can see here as this arc of motion, the rib is going to move in this arcing plane as we do this. So if we're looking at this in, kind of see if I can minimize my screen, get the slide on there. Good. Oh. So we're going to get anterior rotation. So if we're looking at forward flexion of the rib in this region, we're going to describe this motion as being the transverse requires process. This rib is going to be moving in a sense because of the angle of that rib. It's hitting in a posterior direction. It always confuses me because I always think of anterior and anterior flexion. If I'm looking at the body's going anterior, but as we get that superior glide, they'll talk about going posterior, medial, and superior in this direction, the glide. And it has to do with the planar shape of the joint. So instead of being two cups, I now have a planar shape that's like this, and my glide and forward flexion will be up in this plane. Now again, terrible way to learn this online. So again, what we want to be able to do is be familiar with this concept so that when we get to the labs and we talk about this more, you'll get a chance to feel this, palpate these glides, and be able to cement it. But what our hope is that to introduce these concepts now so that you're not trying to absorb all of this all at once. And again, this is just another representation of that joint plane. And seeing here, you can see the costovertebral and then the costotransverse joint, and just how that the transverse process orientation going more posterior. Extension. Extension's easy, reverse everything. So once we get flexion down, everything here starts to move a little bit faster. Try and minimize this a little bit. Bam. Okay. And again, when we think about extension, talk about it as a combination strategy for backward bending. The thoracolumbar spine creates a fair amount of this extension. Generally, what I look for with backward motion here is that the hips will translate anteriorly first to initiate this motion, and then you'll have the motion at the thoracolumbar region, and you get some posterior pelvic tilting, hip extension, are all component motions of this. Now, we'll often see is that if we don't get the hips translating anterior, if we don't get a posterior rotation of the pelvis, we often see hinging in the lower lumbar spine, or we'll get excessive hinging at the thoracolumbar junction as compensatory motions. As we look up into the mid-thoracic region, in most people, there's little contribution from the mid-thoracic region in most people. And those who are slightly kyphotic and fixed, that can actually act as a force accelerator into the thoracolumbar region or the lower lumbar spine. So as we look at somebody with an extension dysfunction, certainly the timing of these things matter, and how we can use, or can we get a little bit more extension from that mid-thoracic region? It's not going to be a lot, but if we can get some more extension initiated from that region, we can often take stress off those areas. But in the typical extension, we have that anterior translation of the hips, posteriorly tilting of the pelvis, thoracolumbar junction will extend, as well as some extension from the upper thoracic spine. But again, it's a very limited amount of contribution. Extension, bludgeoning people. We think about extension, we have a posterior translation of the superior vertebrae. and this is kind of a backward translation in the sagittal plane. The inferior facet on the superior vertebrae glides back and down on the superior facet of the inferior vertebrae. So what we have here is basically with extension, you have both facet joints, which is the inferior facet on the superior vertebrae, gliding back down and posteriorly on the vertebrae below it. We'll talk about the rib head with extension as well. So we also have rib motion, which is going to be a posterior roll of the ribs. The kinematics of the ribs. So osteokinematics of ribs here, left and right ribs, there's a posterior rotation. And again, what I have now, because I'm going backward, is the rotation. If this is the facet joint on the rib, and this is the transverse process. We have this shape in the upper region, and we have this motion occurring. And it's that posterior rotation and glide. Now, oftentimes, again, we can test these glides in multiple positions, but these are ones there. Now, the costotransverse joint is a common site to have a restriction in. It's like a very common, manipulative technique that you're going to see and you're going to use. So restrictions here, it's going to create multiple dysfunctions. And sometimes it's the mechanical disruption here disrupts the pattern of either it can be breathing, it can be rotation. You're going to see these things blend into, especially as we get into these other modules. It can change shoulder dynamics or shoulder kinematics. It can change scapular, kinematics, because of you have all the rhomboids and the scapular stabilizers all attaching to the spinal segment, and we get an aberrant motion at the costotransverse joint or the segments involved. It's going to change the recruitment patterns of these muscles. So if you look at these arthrokinematics, this is a very common one where I find a ring restriction here. It will restrict my ability in these other areas. And it's not so much that it's a articular block and it jams the segment and it can't move around it. It's more that the body kind of senses, functionally that, hey, there is something here that's not moving correctly. Let me alter my strategy to move around this segment. And I alter my strategy in lieu of this restriction. And then I get the breakdown in the system. So when we think about these articular restrictions, it's not always that, I have an articular restrictions and that is a one-to-one relationship to my problem. Many times what we're going to see in the thoracic spine, when we look at these arthrokinematic restrictions, is that this rib restriction at the costotransverse joint that doesn't allow this roll, not only when I extend, but also when I inhale or exhale, is going to change my movement strategy. And these things will impact that. So when I'm thinking about this, it's always treat a joint, restore the motion segment that is restricted, but then it's retrain the movement pattern that may be altered. Many times you'll find that you fix this and the scapular winging that you saw cleans up, pretty quickly, because you removed that functional, that barrier, that kinesthetic sense of, I'm not going into this range the way I should. So it's just kind of good to mention, throughout here that while we look at these joint glides, and especially in the ribs, these restrictions, have impacts in the neuromotor control system. And it's oftentimes what we end up finding and seeing is the causing the problem. And again, here, just going a little more detail there with some of the slides from the article, you're going to see basically with extension, there's posterior translation of the superior vertebrae. We talked about, the inferior facet joints glide backward into extension and posteriorly. And also we have a posterior rotation to the head of the rib at the costovertebral joint and inferior glide at the costotransverse joint. So we see a reversing of this mechanism that we saw in flexion. Again, we have a reverse in the if we look at the costochondral region, then we start talking about that more planar shaped joint and the orientation of the joint being in this direction. So posterior rotation of the 7th through 10th ribs the relative vertebrae requires what they're called an anterior lateral inferior glide. So I know it gets a bit confusing here because we changed the direction, though it's maybe a posterior glide. It's an anterior lateral and inferior glide is how it's described because of the shape of the facet joint. In my mind, how I simplify it is I just like to think of it as okay, the rotations as well. So, it's similar. It's just more descriptive in the shape of the joint, but it doesn't necessarily dramatically change the biomechanic that's happening. It is just a more specific way to describe what's happening at this joint, since the costotransverse joint plane in these lower regions is more planar and it has a slightly more posterior and angular orientation. Right lateral flexion. So osteokinematically, the superior vertebrae, is going to basically laterally flex relative to the inferior vertebrae, and this will be in all the regions. And rotation, it can be coupled contralaterally, ipsilaterally as we do this. And usually we'll talk about ipsilateral couplings, but again, it's kind of like once you get a few miles on you, you can see multiple vectors or poles can create different coupling. So I think standard is always ipsilateral coupling, but again, results may vary as we get into that. And again, it's what they talk about here is if the superior vertebrae is free to allow for the orientation of the zygapophyseal joint, then most commonly it's going to be ipsilateral. So if there's nothing restricted or limiting zygapophyseal joint, they'll talk about typically that this will be a coupled pattern. Arthrokinematics, the glide with light lateral flexion is the inferior articular process of the superior vertebrae glides inferior. So we think about extension on the right side with right side bending. And although it's slightly posterior, that's because of the orientation of the facet joint in that plane. And on the left, it'll be glide superior and anteriorly on the left. So more of a flexion type of glide on that left-hand side. And you can use that in our assessments. Like when you're doing seated assessments, we'll use, I can use flexion and right side bending to assess the left joint's ability to flex. And conversely, I'll do the same. I can extend and right side bend to check the right facet joint's ability to extend. Rib osteokinematics. Okay, with side bending, the ribs approximate on the right and they relatively separate on the left, and all three regions. What happens at the end range talks about motor control strategy chosen, task, and again, the stiffness and mobility of these segments, they'll all vary in what they tend to do in the osteokinematics, but you can think about those ribs compressing on that right side and creating more space on the left side. Again, this slide just summarizes kind of some of the points that we had talked about. But coming back here, it's, generally we find that we have, hey, a right side bending restriction, like we look at other things, then we start to think about, okay, if it's segmentally driven, I start to think about, okay, what can't these joints do? Here, what we're seeing here with side bending, because the vertebrae keeps moving into extension here in the superior one, what happens is we get a relative, roll of the rib because there. So let me go through this here. So we get that roll. So oftentimes when we look at lateral flexion, what will end up happening is the rib gets restricted before the facet joint and the segment stops moving. Segment continues going, and it creates a relative roll of that rib in these directions. So on the right, it'd be a superior. You see there on the left, it would be an inferior roll. And it's just kind of due to the fact that the rib, because they abut, stops earlier than the thoracic segment. Rotation. Now, with rotation, this is where we start to kind of think in terms of, we're talking about each segmental motion, but that's where we start to get in that concept of the ring. And again, we're going to talk right rotation. If you look at right rotation here, she'll use this green ribbon here to denote, a small amount of contralateral translation that occurs between the superior segment and the inferior segment. And this is one that, you'll see us in class use a traction, technique for. These translations often get restricted. And you think about all the rotation activities we do, from a checkout person to me sitting here kind of cockeyed and rotated to my right. What we get is we get this intersegmental, this bit of translation. Now, oftentimes what happens is we get stuck in these translations and we go to come back and the segment won't recorrect. You can think about the rib getting jammed, the facet joints getting off axis and getting stuck in this position, causing these types of rotary dysfunctions. The rotations and the anterior translations can often be some of your more painful thoracic problems that you'll see. And many times when you get into the biomechanical exam for these rotations will be like, you're gonna feel like everything's stuck. But there's kind of a way to kind of check this glide. Like when we do the rotation checks in the spine, there should be a bit of give. You should be able to take each segment and almost jiggle it left and right on the superior segment. And it should have a bit of pliability. And we're going to look for that. But this rotation in this segment, again, it's the kind of that conjunct motion. It should occur with rotations that we have. We don't have muscles which pull me into this translation, but it's a component motion that we do. And that's what this ribbon and that rotational arrow is kind of demonstrating it to me. We can see here as we rotate, to the right in this case, we're going to get an relative inferior glide of the right inferior facet joint into extension. We're going to have a relative superior glide of the left inferior facet joint. And again, the red arrows here indicate the anterior and posterior rotations of the ribs that occur in the conjunction with the contralateral translation during right axial rotation. So what you get is you get a ring twisting as you do this. So confusing, I'm sure, at this point, but I think about it this way. The ribs act like your innominate. So if I'm trying to remember which way I have the ring translating or which way the ribs are rotating, if I rotate my pelvis to the right, my right innominate goes posterior, my left innominate rotates anterior. And the ribs follow that same motion of rotation. So when you think about the ribs and you're like, okay, which way is this segment going? I basically rotate my pelvis a little bit and think, okay, my right innominate went posterior, my left innominate went anterior. Ribs follow this convection or convention, and that's how you remember it going forward. So I know that there I'm going to get this rotation of the rib to the right rotation. I'm going to get translation in the opposite direction. And I know my facet joints are fairly similar. It's going to be extension on the right and relative flexion on the left. So if I have somebody stuck in a right rotation, I'm going to look for, do I have a translated segment? Are my facet joints able to flex and extend in the direction that's appropriate for this rotation? Do I have a restricted rib glide that could potentially be locking this person up? And if you feel like the whole segment's not moving well, I'll do a left and right lateral translatory test to test the ring and see, okay, is this thing just living over to the right? Like when you do that, you'll find that like in this individual, this ring won't want to translate from left to right. It is stuck in left translation and right rotation. So when I go to push on it from the left, it won't go to the right. When I push from right to left, this ring will have a little bit of play in it. It likes that direction. It's living over there. So it likes that position. Again, and as complicated as these translational restrictions may seem, and they can be tricky to identify, the fix for them is probably the easiest one in the manual therapy world, which is seated traction. I can also do it supine their body alignment doesn't allow me to do it. But then the seated traction technique, just doing a lift or a drop technique in the thoracic spine, super effective. These joints make a, when they're stuck, they make a clunk. You'll know you got it because this joint's going to just clunk on you when it happens. And generally, it'll kind of take the bite. I expect it to take the bite or the edge off of that individual. And it's going to greatly reduce their symptoms right after I do it. Yeah, we talked about this a little bit already. The osteokinematics, the superior vertebrae rotates in the same direction as the axial rotation. So the rotation is to the right. And then there's a slight contralateral translation in the transverse plane. The superior vertebrae on the inferior vertebrae. Arthrokinematics with this, with right axial rotation, the inferior articular process of superior vertebrae glides inferiorly, slightly posteriorly on the right, and it's going to glide superiorly and slightly anterior on the left. Costal osteokinematics, right axial rotation, the right rib posteriorly rotates, and the left rib anteriorly rotates. Think of your innominants, same as the innominants. And I was thinking how to work this all the way up to the clavicle. If you need to remember with rotations, which way does a clavicle rotate? The clavicle follows the rib conventions. Next one. Arthrokinematics, the costotransverse joints, 1 through 6. The right rib glides inferiorly and rolls posteriorly, while the left rib glides superiorly and relatively rolls anterior on the transverse process. And if we're looking at the lower costochondral region, 7 to 10, during right axial rotation, there's a planar articular surface of the right rib glides anterior, lateral, and inferior, while the left rib glides posterior, superior relative to the transverse process. See how the terminology is different, but in essence, the direction of the rotation, if you think about it, is the same. So this isn't like a dramatic shift in rib biomechanics. It is a subtle change. It is a change in the facet joint plane. And again, it's just sometimes the manipulative technique we move, we can accommodate that glide slightly differently. And again, we have rotation. We'll talk about, greatest rotation in upper segments, other than that's compared to the middle segments. TL junction will give us the most rotation. It's a joint designed to give us rotation. Again, right rotation causes posterior rotation of the ribs. And again, these are just some other general terms in there. We think about pump handle and bucket handle motions with inspiration, the pump handle and bucket handle motions. We think about breathing in, and you can all do this right now. You're going to breathe in. And we're talking about the superior segment here. They'll talk about on the right-hand side of this image, you'll see that, look at the transverse plane of the joint and that one where we're doing the bucket handle, motion on that right side of the rib. Look at the costotransverse joints a little bit more, how it goes backward, how it's in that plane. Where when we talk about the pump handle, we're talking about the rib motion on the left, where it's going to be that superior motion. And again, with exhalation, we're going to reverse that motion, but you can kind of see how the costotransverse joint, costovertebral joint, and the different axes of motion are going to dictate a bit of that pump handle versus, again, the pump handle versus bucket handle conventions that we talk about. So again, with inspiration, expiration, again, that plane of that costotransverse joint, you can see how it's going to impact the pump handle and bucket handle motions that we're going to have. Again, neural dural implications. Sympathetic chain is postulated to be affected by flexion and contralateral rotations. Thoracic manipulations can decrease lower extremity symptoms and and studied postulate due to neural effects. I think maybe once a year, every 18 months, I see somebody with dural tension, and it's the restriction is in the thoracic spine. And oddly enough, you'll find it's in the costotransverse joint because of the way the dura is an attachment. It's tethered in the thoracic spine. And you're going to find that, as odd as it seems, you're going to be able to do a costotransverse manipulation, or you're going to be able to do basically a seated traction technique for a translated segment, and you'll be able to decrease the dural tension in these individuals. They will often be the ones where it's like you go to do the slump test, and a slump test reproduces their symptoms, but maybe the straight leg raise test isn't quite as clear. And that's where I look at the thoracic biomechanics in those individuals. Here we're talking about, manipulation things. Now, some of you are old enough to remember ERSLs, and I can't remember the flexion rotated side bend left. They used to use osteokinematic terms, which were a little more confusing to use. We kind of moved away from them generally as profession, and just to describe the lesion that we have. So you're not going to hear me talk about ERSLs or FRSLs and restrictions because it's an older term. We're going to use terms of things, talk about like flexion restrictions, and it's an inability, to rotate forward in the sagittal plane. So something that I have a flexion restriction, I can have extension subluxation, which creates a flexion restriction. We want to talk about it in the convention what we have. So flexion restriction, inability to rotate forward in the sagittal plane. What can cause this would be potential causes: impaired superior gliding of the facet joint. We have a facet joint which is stuck into extension. Is there, one model B, is there reduced anterior translation of the superior vertebrae on the bottom? Is the vertebral segment itself restricted? This due to osteophytes or bony growth, disc degeneration, reduced anterior rotation or internal torsion of the ribs. So if we have an inability to rotate forward in the sagittal plane, is this being caused by the ribs' inability to rotate forward in this plane? And again, what we can also have is, segmental or multi-segmental restriction of the rib joints. Many times you're going to see if somebody's been fixed in a position for a while, you can have more multi-segmental, more capsular type restrictions occurring than, in that area. So when I find something that's multi-segmental, I don't think of articular restrictions often as being, okay, I found it in 3 different segments. It's usually going to be isolated to one. That person who's kyphotic and has been that way for a while will lack extension, and because of changes in the vertebral body and the soft tissue structures that surround that area. Flexion restrictions have been described as being more common in the upper and middle thoracic spine, anywhere from T3, T4, T6, T7 is one example. This would be an extension subluxation, and a relative straightening or reversal of the normal curve can be found. They can be symmetric or asymmetric, and it can be caused by whiplash impacts. And sometimes with this, you're thinking about, you can have subluxations, but it could be flattening of these curves as well. And here in this picture, what we see Jim here is he's basically testing, and how we're going to do it in the seated position testing motion. And here they have the individual basically flexing forward. And in the upper thoracic spine, you can do this with the head. Like you can have the head flex forward, and those upper thoracic joints should move into relative flexion. And you can see Jim here starting his P pivum and his P pavum, gliding that inferior facet joint on the superior vertebrae superiorly and anteriorly into the joint plane. Here we see this joint has the inability to glide posteriorly or go into extension. So here what we have Jim doing is Jim is blocking He can block both sides, but my guess here, what it looks like he's doing is he's going to block the left side, probably with his thumb. He's got his index fingers on the other side. He can extend the segment straight back, but then he can add a little bit of left side bending to bring the left inferior facet on the superior vertebrae into more extension over the inferior segment. So he's using his left arm to extend and side bend to the left to test extension of the left facet joint. And from this position, as we'll learn in the courses, what we're going to do to kind of test this extension moment is he can, rock the patient back with his left arm, controlling the trunk, or he can put his thumb on the inferior segment and push the inferior segment up underneath the superior segment to assess the glide. See, can I glide this segment? Has it lost its ability to glide? Is it restricted, or is this more capsular in nature? I think you will see in here is that, the more harder ones, the subluxations, I think, are easier to treat than the hypermobilities that you incur in here. That's the case pretty much with a lot of segments. And it's not uncommon sometimes, especially somebody doing some type of rotational activity, to get hypermobility in one of these segments. And when you push on this, they're going to make a noise, something like, oh, because it's going to reproduce their symptoms and you're going to get a soft end feel. And it's not uncommon. I definitely see it in CrossFitters, rotational athletes like lacrosse players. I'll definitely get it in. Occasionally tennis players, but not quite as frequent. It's usually the more ballistic movement activities. You'll see that. And you'll also be able to assess or to go into that the segment itself can become slightly, get hypermobile or unstable, and you can have this bilaterally. But typically what I'll find is it'll be unilateral based on either a pattern of the patient's preference or the activity by which they do more commonly. It involves a rotation or a side bend component into that direction. Range of motion assessed at active range of motion. We'll talk about usually assessed in standing. Inclinometer can be used if you want to quantify the motion, and assess the pain and symptoms with motion. Peripheralization, centralization, extremities along with the rib. Now looking at motion here, yes, I look at it in seated and combined because I want to kind of get a sense of, okay, what is the patient's flow? What are the hips doing in relative to the thoracic spine? Which one may be moving first? Which one may be moving excessively? And see that motion. Again, and then I'll follow up that active range of motion assessment with probably more of a passive or a guided range of motion assessment in the seated position to then see, okay, if I eliminate the pelvis, now I can kind of start to kind of look more segmentally and specifically into those regions. But it's kind of where we're talking about that flexion extension. And even what we did in the lumbar course, and we looked at a bit in the cervical course too, of just understanding what is normal kind of flow. How does movement move through the body? And when I'm a little bit left of center, those are the easy to fix things where it's like, hey, my pelvis isn't flexing as fast as it should or as much as it should. And my thoracic spine is making up this ground. So now I'm asking my thoracic spine to do a bit more than, what its ideal, load would be. So that becomes very important to me to kind of see, okay, what's the low-hanging fruit for this individual? How can I get him better faster? Models and systems help therapists assess, individual levels. End range evaluation, we talk about, PIVMs and PABs identify these markers of dysfunction, improve pain and dysfunction. And that's kind of really where we kind of get into this, of looking at these individual joints and being able to kind of be more specific, because finding a hypermobile segment is just as important to me, probably more important to me than finding the restricted segment. I can find restricted thoracic segments in just about anyone. And many times they aren't causing problems. Other times they can cause significant problems in a pyramid, especially if they haven't had it before. Generally, it's not a pattern they flow in and out of all the time. There's stuff off axis that can become quite painful and quite limiting. But not only that, it's, we talk about as we get into the shoulder mechanics and even some degree pelvic mechanics, these subluxations and restrictions can drive neuromotor dysfunction elsewhere. So, you're going to run into these where, yeah, you need to look at your thoracic spines and your cervical spines in your scapular dysfunction patients and at least get an appreciation that, hey, I don't see anything standing out here. I don't see an influence to rule it out. And again, you may find that sometimes that may be your second session if you don't have time in your first eval. There is nothing wrong with saying, in the next session, I'm going to take a more detailed look at your thoracic segments and see, do you have the driver there if you don't have time? So don't beat yourself up if like I can't get it all into my eval. I'm pretty easy on myself now. If I miss it and I have to do it in the second assessment, I have no problem just rolling it into my next one. But you'll generally get kind of an idea early on. Huh, this seems like there may be a vector coming from somewhere else, and that could be the cervical spine or the thoracic spine. Your assessment light palpations, we're looking for, you can look for tenderness, lateral to the spinous process, looking for segments of hypotonicity or hypertonicity. Feeling a hypertonic muscle tone at that segment locally is usually kind of going to correspond with finding a rotational dysfunction, a ring translation, or a segment that is, subluxed. Because you're going to see also that you're going to see a lot of ring translations which are not articular restrictions. They are myofascial rotations. Oftentimes, either they could be the primary driver that ring finds stability and being shifted to the left, or it's compensating for something above and below it. It could be that there's another thoracic segment which is shifted and irritable, and that segment that you come onto when you go to glide it, man, there's no restrictions, but it's being muscularly held in that vector. And that is probably a corrective segment. That the body is using that to correct the alignment coming up the kinetic chain. A good way to think about this coming from the lumbar world, we talked about this a little bit. If I have an anterior nominate, rotated anteriorly on the right, posterior on the left at the innominate, it's going to create a left transverse plane rotation of my pelvis and my thorax. So I could have something up here as high as, where I'd say Jim's at T7 here. I could have a left transverse plane rotation of my pelvis, and I could have a right transverse plane rotation of the segment as the segment correcting that segment from below. And again, we could also see that I could have this could also be correcting something coming from above. So as you get in here, you're going to find these segments. And when you get in here in these palpations, it's good to know as I get to this segment, it's translated. If I can check the facet joint and the rib glides and the rotational mobility, I can then determine, is this an articular restriction? Is it facet? Is it rib? Or is it a translatory or dysfunction? And then that'd be manipulable. If it's myofascially wound in this region, then I need to try and figure out what's the potential driver of this. Why do I have this? It's all relevance, especially if you're needling and looking to release these muscles. It's like if it's an articular driver and you needle it, it's great. It's going to work. It's going to work for about 6 hours, and then it's probably all going to come back because the articular driver is still there. If it's myofascially held and you needle it, then you can release that rotational hold or grasp that segment has. But again, if this isn't the primary driver, then it may just return as it goes to correct for the innominate in that pattern. Or if this is the primary driver, then you clean it up and they love life and they're doing great and you look really smart. So I always like to kind of get a sense of, I treat these and then I kind of see what happens when they come back. These things where if it's like, it's myofascial, I decrease the desensitization, they feel good for, 12 hours that night, but later that night, maybe the next day, their symptoms come back and then they're kind of, back again. If it's an articular restriction, I expect them to be 70, 80% better. The bite's really gone. I got low residual soreness, and then it's cleaning these things up. And that's kind of where, that assessment really becomes that full assessment. So whether we're doing, manipulations or we're looking at myofascial interconnections, understanding the pivum and the pavum, with the thoracic quadrant, the segmental mobility, but then also assessing the tone in these local areas to see, do we have tone that may be driving it there in the absence of an articular restriction. Again, rib assessment, See, a lot of things can cause rib dysfunctions. You can check any person in your clinic right now, and you're probably going to find some rib dysfunction in somebody. Here's kind of a classic position of the hand if we're going to be, looking at gliding the rib or even manipulating the rib in a traction technique, which we'll do in that thing, where you can see that thumb is sitting on the rib just off of the transverse process. So you can think about that position as the position, I often use this to mobilize or manipulate the rib. And that's how we can kind of assess some of the rib glide. There's multiple ways to kind of assess the rib glide, and we'll get into, all of those in the thoracic course. And again, you often find here, so we'll talk about the key rib is usually the superior segment, which limits the inferior segment. And the way we think about that dysfunction is, let's talk about like a right rotation in a sense. So if I feel like, hey, this right ring is stuck to the right and it won't translate left. Often what you're also going to feel with that, you're going to feel a rib bump on the lateral angle of the rib, where that rib feels like it sticks out a little further on the lateral side. And that rotation is typically contralateral, where the rib is shifted to the right, rotated to the left. And it's usually going to be like, okay, it's the superior segment is usually the driver. The inferior segment isn't the one that's shifted to the left. The superior segment is usually one that they find by convention is the one that's restricted and the one that we'll end up treating. And again, movement restrictions, kind of getting back into terminology. If T1 is limited extension and going into extension, we have a flexion subluxation. In this case, what we'd find is, okay, T1 is prominent. The unilateral symmetry is more pronounced on the extension on the side of the side opposite the restriction. And again, what we can also palpate here is that the spinous process may not approximate during extension. And again, these are kind of common patterns that you will see in the thoracic spine. And there's different schools of thought will often define this as that, but T3 to T7 is often limited in flexion. These are usually kind of extended segments, extended in normal posture. Ability to move into flexion at these segments. On these, you'll feel kind of flat, it'll be flat on palpation. There'll be a loss of basically, the kyphosis here. Again, these will often, as you can see here, there'd be more prominent inflection with the transverse process more prominent on the side of the restriction. And then also the spinous process, will not open during flexion. These people live in an extended posture. It's kind of a more common pattern that they see. Often we define that with T8 to T12, you're going to see more limitations in extension. The flexed posture, limited ability to move into extension. And you'll see kind of these alternating patterns of flexion extension. Again, these are common patterns that you will bump into. These are not hard and fast concepts. So it's just nice sometimes I go into where it's like, yeah, you're going to see these things and these trends seem to show up. We're going to see certain segments flattened out. And you'll see other segments slightly kyphotic. So this is kind of some of the normal conventions that you might see. Common patterns of rib dysfunction, limited flexion in thoracic segments. One of the common things you'll see with rib dysfunction is decreased rib cage excursion during respiration, and loss of costotransverse mobility. These rib torsions or external rotation of the ribs. This is another convention term that they'll talk about. And you can just think about how those ribs get torsioned as we rotate, or again, the rotation as we breathe. Again, if we talk about the extended posture in the mid-thoracic, there's limited motion and deflection. So there'll be common patterns that you're going to bump into in the thorax that we'll see. These are a couple of them. I don't get into too much detail in these because essentially once we get into these common patterns, I'm really kind of assessing the mobility of all the segments. So within the segments that are typically in extension, I want to know what's the segment's ability. Does it have the ability to, if it's stuck in extension or living in extension with loss of kyphosis, does it have the ability to flex? And then how do I, one, encourage that mobility? Then how do I then retrain that mobility to move in those segments? Because we get kind of patterned in our thoracic spine biomechanics. We kind of learn that, okay, I don't extend well through these segments. So you essentially stop trying to extend through those segments and your pattern moves around it. So if you're slightly kyphotic there, maybe your scapula doesn't draw back and you don't pull in with your extensors into that area that's slightly flexed and kyphotic. So you stop trying to extend. But when you do the biomechanical assessment, you'll find that, hey, this person has the ability to extend through these joints. But when I watch it move, they just don't do it. So, I mean, you saw me doing some of the stick mobility stuff in the cervical course, and that's where I look at where can I now direct my mobility and my neuromotor retraining to take these segments that are generally kyphosed and don't extend, but have the ability to extend. How do I retrain that specifically? And that takes a little bit more work than sometimes some of the conventional exercises we have. But that's where manual therapy is very valuable because by me mobilizing and putting proprioceptive input into those segments into extension, I often see that it improves their ability to extend through those segments by raising their awareness of it by that feed forward mechanism. If you're looking at some of the brain, the kind of the brain imaging and some of the neural drive portion of it, does it create that kinesthetic awareness in the brain for descending inhibitory control? That's an interesting area as you look in manual therapy that they've been writing on more, and why manual therapy is now more in vogue is a lot of its impact on the brain's ability to control the segments. So putting proprioceptive input into those thoracic segments that may be multi-segmental, mild capsular restrictions, joint mobilization there may have a lot of value in getting that person's ability to control and have that as a contributing segment. Whew. Hope that wasn't too dry. I know it's kind of a lot of detail and it's good to put it out there. I'll try and get this posted quickly so you can review it and see it. So to give you just an idea of this, and we're gonna spend a lot of time on this. So all of a sudden you're kind of scared or this seems like it's a lot. Don't worry about it. We're gonna spend a lot of time and working through it, and you're gonna feel it so much during the lab course that by the time you finish, you're gonna feel pretty solid with this. All right, good people. Go have a good day. Go be productive. I'm gonna go get a drink of water.